Ahead and call this meeting in order real quick, and we're gonna try, if we can, to go through as much business as we can as quick as possible, so we can get him off the phone, he can go back to relaxing. So I'll go ahead and call this meeting to order. This is the meeting of the Mason County Board of Health, January 28th, 2025, so welcome everybody. I need an approval of the agenda.
I make a motion, we approve the agenda as presented.
I'll second.
It's been moved and seconded for the approval of the agenda as presented. Any comments? All in favor signify by saying aye.
Aye.
Any opposed? Okay, the motion carries. Resolution to set our list of meetings for 2025 and the dates. Can you do it in short form?
No, because Dave would like to see us meet every other month instead of quarterly, because he has plans, and I think that might be a good idea.
Okay, then make a motion.
I make a motion, we meet every other month instead of quarterly.
Okay, we'll see if there's a second. Is there a second?
Second.
Okay, it's been moved and seconded that we meet every other month instead of quarterly. Is there any discussion?
Do these set dates?
It'll be the
We can send it out.
Okay, that's fine.
Perfect.
Okay, any further discussion? All in favor signify by saying aye.
Aye.
Aye. Any opposed? The motion carries. Next up is election of officer positions. Commissioner Trask, you had something you wanted to say, right?
Well, I would love to nominate Darren Moody as chair.
I'll second that. Will you be willing to serve if you're elected, Darren?
Just talked about me running next year for this. Sure.
Okay.
Then you
Yeah.
seconded.
Is
already.
there any other nominations for chair? Are there any other nominations for chair? Are there any other nominations for chair? That's three. All in favor signify by saying aye.
Aye.
Aye. Any opposed? So I'm gonna ask you, Darren, would you like me to finish with the rest of the meeting and take over the next month, or?
You
Okay,
go for it.
so that's what we'll do. We'll get this
You're
through
on a
this
roll.
quicker.
Don't stop me now.
Next up, I'm gonna need a nomination for vice chair. I nominate Peggy for vice chair, if you're willing to serve.
I don't have a problem with that.
Okay.
I'll second that.
All right, it's been moved and seconded for Peggy for vice chair. Is there any other nominations? Are there any other nominations? Are there any other nominations? Hearing none, all in favor signify by saying aye.
Aye.
Aye? All right, any opposed? The motion carried, and you are the vice chair. Next up is item number 5, approval of the minutes, August 13th, September 17th, and October 22nd, as presented.
I so move.
Okay? Do I hear a
I'll
second?
second.
It has been moved and seconded for the approval of the minutes as presented. Any comments? Hearing none, all in favor signify by saying aye.
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 Aye. Any opposed? The motion carries. Okay, so next up is the health officer report, and I hate to do this to you, but actually, Pat, if we have permission from the rest of the board, do you mind if I go ahead and excuse him? We have no more action.
We have one more action.
One more action.
What do you got? Oh,
Administration.
we do. Sorry,
Acting
Pat.
health
But we can
officer.
jump to that now.
Let's go
Yeah.
ahead and jump to that now so we can get him off the phone. You don't do this.
Okay, so every year we have to approve who will be acting health officer if our health officer is indisposed for whatever reason. In the past, we've done a couple of ways. I have an MOU here with the state, so to provide what we already have in place, is they're called regional health medical officers, because they can't be a health officer unless a board allows them to be a health officer, in which case they would have health officer duties for that period of time. So the contract is in there just for the state, it's already provided, there's no cost, and then I think that would give us up the stuff on that.
Do you have a page?
Yes, page 21.
I don't know if I even printed that off.
It's quite a ways in the back here, but I can give it to you.
So I can make a motion that we approve the interlocal agreement for acting health officer coverage between Washington State and the Department of Health.
Do I hear a second? There's a motion on the floor to approve the, how do we want to say it again? The agreement between the Washington State as becoming our interim or our
Backup health officer.
backup health officer. Any discussion? All in favor signify by saying aye.
Aye.
Aye, the motion carries.
Okay, Pat.
Have a great one, Pat. Thanks for giving us that minute so we could do this.
No problem.
All right, sleep well. You sound like shit. You sound bad.
He sounds bad.
Yeah, thank you for not coming in. Okay, so, next up, if you don't mind, health officer's report.
Sure. And I don't see the health officer on, so,
You wanna give a simple one from your side?
yeah, so we've had a number of things that have come up in the last month. Some relating, or several months, relating to bird flu. So we know about the wild cats, the large cat
Oh, the
facility,
The sanctuary.
sanctuary, and they had a bad round with bird flu. I think they've lost 20 of their 36 cats.
It says
Yeah.
20 in one report and 21 in the
Yeah.
other.
I was gonna do that too.
So about that. And then this last week, we had a report of a harbor seal that was tested positive and died of bird flu. So,
Wow.
and that wasn't in Mason County, that was one of our neighboring counties.
Doesn't matter. That's a heck of a thing all by itself.
Yeah, it is. So the bird flu is definitely a thing that's out there. Our health officer is also the health officer for Benson Franklin, and he's been working on all those poultry farms.
Does this transfer through fecal?
It does.
This is the reason we're paying $10 a dozen for eggs.
Yeah.
Yeah.
Well, there's something to bear in mind that we should notice around here. If it does go to the seals and stuff like that, summer starts coming up and it starts swimming in your feet and everything, starts going in that's something we should consider. I don't know if you have any solutions, which I don't think anybody does, but it's time for you to start looking at options for that to bring
Right.
us, I think.
So we're watching, in Washington, I think we've had one case that's transferred to humans, and that was a worker in one of the poultry farms that was disposing of the chickens. So as far as I know, that's the only thing we've got going there. Flu season is, and I put that in my report from the director, got off to a later start, and it's a lower cap on the flu season, so that's good news for us this year. So flu is not nearly as bad as it was previous years. So that's good. Death rates are down across the state for flu. And I think we're at like 4%, I wanna say, influenza-related illness at the ER visits in the hospital, so. And COVID is down, it's down, it was at 2%, now it's down to under 1%, so.
Aren't we amazing?
Yeah, you know, it was funny because in December they said, COVID has doubled. Yeah, it went from 1% to 2%.
Now it's back down.
So now it's back down, so it's, yeah, it depends on how you report on your statistics. So those are the big things. Dr. Kreger is coming in next week. He'll be in working with staff next week. And things are going pretty good from that point of view. We've got a new Secretary of Health, interim Secretary of Health and that's Jessica Todorovich. We've worked with her in the past. Dr. Kreger has worked with her extensively. So we got a good relationship there. She'll be meeting with the health officers Thursday, and then she'll be meeting with all of us directors on next Tuesday morning. So looking at good things there. She is the chief of staff and has been at DOH for a long, long time. So
Your relationship with her is
oh
good?
yeah.
That's the one, I thought that's the one we talked about before, okay?
Yeah, she's a good egg.
That's a good thing for us.
Yeah.
Yeah.
No,
You know.
no, she's a good person to work with. So yeah, so that's it for basically the health officer.
Okay, well, what do you got next for administration?
So much stuff. So, Board of Health positions. So, we've got some that have not been attending. So,
Do we have something in our bylaws about it?
I think so, yeah.
I
So,
think it was
we
like
may need to
three-
approach,
Used to be 3 meetings.
missing 3 meetings,
Yeah.
and so we need to talk to the city about, does that person want to continue? And if so, that needs to come to meetings. We also have 2 open positions, and we also want to talk to the tribe about making sure that we can get,
I thought she was here last time.
She was.
she was.
Was,
Yeah,
Yeah.
I want to make sure it's as easy as possible and she can get on Zoom or whatever.
And she's from Squaxin, right?
Yeah, from Swanson.
We
well,
don't
it
have
may be harder now that we
representatives.
just expanded how many meetings we're having too,
Yeah.
just be.
Yeah.
Yeah,
that-
so I'll talk to her. The other thing is we still have the 2 open positions for community health members. So we've got those 2 available, and I will put those back out and we'll stick that in.
Define, please,
What's that?
define.
Oh, okay, so the way the Board of Health is organized now under the rules that came out 2 years ago, and we were already there. It expanded the boards of health. And 2 years ago, they categorized what, so you have your electeds. So, and the electeds can be no more than 50% of your board of health. But you have different categories. There's users of public health. There are public health professionals, so doctors, folks in the hospital, and
So you're saying providers and users, is that what we're breaking it down to? And we have a C for a provider?
we've got these two are our providers. They represent the provider piece of it. We don't have anybody for a community member.
He's elected, okay, so you need a community member, a user.
Yeah, so electeds are only city and county officials.
Okay.
So it does not apply to hospital boards or commissions. So in the legislation, it defined just city councilmen, county commissioners / council members. So those are your electeds.
So the two community positions are just at large city?
Yeah, so users of public health, which really that's anybody.
Really broad.
Yeah.
If you guys, I don't know, I've never talked to her about it, but I've worked alongside with her 100 different things over the years, and sometimes she can take one side or whatever, but for the most part, I always find her to be in the middle. That's Delma. Do you guys remember her?
Yeah, she attends quite a few of the community meetings. She's a great person.
She,
I think we should maybe put something in the newspaper.
Okay, yeah, I can do that.
And that way we're not picking and choosing, we're putting it out there so people can.
well, you get it out of the newspaper, we'll be picking and choosing. There's gonna be, let's hope, there's 20.
Yeah.
Well, that
That's
would
good
be
too, though.
nice, but you'll
That's
be
not a bad
lucky
thing.
to get one or two.
Yeah.
Yeah, getting
Yeah.
more in body sometimes is just not the
So the
right.
process to be placed on this board is pretty, it's just the board picking it, right?
Yeah, it's board picking it up.
As long as they meet the requirements set by
Right.
the state.
Yeah. So, and that's outlined in RC30. I can send that back out again. So, yeah, I mean, we were way ahead of the state. A lot of places really had to, jump through some hoops. So we're allowed to do two things. We can expand our board of health, or we have a small board of health with just the electeds, but then you have to have a community advisory board, and that's a really big board. And we were already there, so we can go that
And
direction.
we changed here quickly out of necessity.
Yeah.
I just started. I had another commissioner who had just started. She was only 5 weeks before me, and another one was never there. And we're sitting there in a meeting, and it turned out at the time, we were the only ones that were voting. We had all these great people. We had Hilburn and everything else, and we're waiting. I was the chair, and I'm waiting, and nobody in there saying, well, you're the
You
ones.
have to do it.
And we're like, what? I look at each other, we have no knowledge, we don't know nothing, and we're the ones in charge of the health department. So we brought it forward to have the people that had the know
Right.
make the decision. That was a pretty foolish rule we had going on here.
So we're ahead of the game. We were challenged on it a little bit last fall, that we weren't aligned, and we are aligned with what the state regulation says, so. We just need to get those two positions in.
Maybe send something over to Shooty now that he's part of EDC over there, if he might have a business person that might be interested.
That would be a really good idea.
Okay?
What else you got?
Okay, so strategic plan, I was gonna talk about just basically the three things that are the hottest items on my list. And they're kind of big things. So, I've been working on getting the family planning clinic up. So I spent a lot of time on the phone the last week looking at electronic health records, and we talked about this, last year. But I just got off the phone a little bit ago with Nightingale Notes, which is owned by Champ Software. And it's what we've been using. And they're a much smaller electronic health record. And she gave me a presentation on the new Gold program. So, let me back up. We have our electronic health record on a shirt tail arrangement with Kitsap County, who uses Nightingale Notes, and so does Jefferson. So the three of us are working together with Nightingale Notes. Kitsap just upgraded to Nightingale Notes Gold, so we'll be getting some training on the Gold. We were looking at doing an EHR that's either the same as the hospital or the same as Peninsula Community Health to get that interoperability. So in my conversation with her this morning, I stressed the two things that are very important to me with Nightingale Notes, and they have to meet these things, or we'll have to look for a different EHR, is we have to have interoperability with our other systems. So Athena, Epic, Cerner. Those are the three big ones around us that we would be handing clients off to. So we've got to have that. Just gonna look it up. The other thing is, how do we do billing? And it does billing, but, and it uses a third party. We can do it internally, or we can use a third party, and they have a third party group they work with. And Nightingale Notes would generate the claims. So we have to be able to do, if we're going to open a family planning clinic, we have to be able to do Medicaid billing, we need to do insurance billing, we need to do private pay, and sliding fee schedule. So, and she says they can do all of those, and it would just take some work to get it lined up and submit claims and that kind of thing. Same thing that the jail would need to do, or probably already does. But if the jail goes to further into the reentry program, they're going to have an EHR that integrates as well. If the EHRs don't get to a place where they have interoperability, the state is going to be coming out with their own EHR for jails, prisons, public health, that they're developing through the healthcare authority. So they're looking to invest, I think it's like $81 million into developing a product that we would all use. I'd rather have one that we like and we use and we can depend on and already up and running. I don't want to wait however long it's going to take the state to get to that point.
Might be 2 years.
It could be 2 years, it could be 4 years, you know. I mean, we've seen this, the process with the state and technology. Technology moves way faster than the state can adapt. We saw that during COVID when, a year into COVID, the entire data system crashed and we weren't able to pull data for months afterwards. You know, up until it met a certain point, and then it stopped working and it just did not work after that. I was not able to pull reports. So, and we have the same problem with other state agencies. I think that Nightingale Notes would be our least expensive way to upgrade and get into family planning. We can go with the hospital and operate off the hospital as a tertiary clinic, and then use their EHR, and then we would have to have a firewall between our billing and their billing. We can do it, there's more to it, more expense. So we'll see what Nightingale Notes has to offer. We'll get together with the nurses and run through things that they see needs to be in there, and I'm sure those are all covered. We went through their presentation, and basically anything you can do in family planning is covered, and they have good reporting on, you know, here was where you started and say STD rates, and then here's where you are now, and able to track those, or pulling that data out of the EHRs and putting it into a graphic form. So that's the first thing, is to get that up and running. We need an ARNP. We have the advertisement out. We've had no nibbles. I think we need to open that up to physician's assistant as well. It's easily done. We've got Dr. Krager. They can work under his license. So we can open up to a PA. So we'll get that done here shortly, get that sent back out again. Looking at adding a clinic manager. So at EH, we added the essentially deputy manager for Ian. So Vladimir is doing that piece. We need to do the same thing in community health, so we have somebody who runs the clinic, not Melissa. So Melissa can concentrate on the bigger picture and let a clinic manager manage a clinic.
Right.
So we've got the support staff already in place. We've got people who can do the Spanish speaking and can do that work. I think we're going to be okay on that. We just need to get a clinic manager in there and an ARNP. And I think we'd be up and running. So it wouldn't take that much to get going. So the services offered would look like family planning, medications, IUDs, LARCs, long-acting, reversible contraceptives. So those sorts of things. No abortions, no referring to abortions. That's outside of our purview. So that's where we would be going. That's one big piece. Our mobile medical is next, and we're getting ready to come out with request for bid. Went through the procurement training last week with McKinsey. We were on the same webinar on procurement, and we're at a weird spot with that. The truck, the vehicle definitely could do a request for bids. But there's more to the vehicle than the vehicle. It's also the services that go along with it, the IT, the service and support piece. So I'm trying to figure out how do you get that rolled into a bid, or do we do a request for proposals, or do we split the two things? So I'll be getting with Mark and we'll see if we can get that figured out, so I can get that out and advertised. We've got, I postponed it last fall and I realized there are a lot more hurdles than I had anticipated. So I want to make sure that when we do it right. We're just going to do one vehicle and move forward with that. So that's going to take a little bit to get going.
Now, would that be similar to what, or could we use Bo's, I guess his plan, because he's got one that's similar, right?
No, this would be
No.
different completely. So we'll do the syringe exchange outreach, but also gives the ability to take family planning and WIC on the road. So it's a different model completely.
So you have to have room for,
An exam room,
Yeah.
and a reception area.
Fresh one, what vehicle were you looking at?
It's a custom build. Yeah,
More of a motorhome, not a tow trailer or anything like that.
not a tow
Right.
trailer, no.
right,
No.
you have to have
Self-propelled.
room for
Yeah.
exam room.
Yeah, yeah. So I talked to Seattle about how they do it. They do it both ways. But their clinics are big. They've got a mammogram clinic, which is an extremely heavy piece of equipment. So that's on a trailer, which they will set up and leave in place for several days. They have dental clinics that they'll set in place for several days. Their smaller clinics are more like what I'm talking about. They can run around and do things, but they have more employees with Seattle King County Public Health than
Right.
DOH has.
Yeah,
So it's just a bigger thing. I have looked at the PCHS model, so we've looked at their vehicles, been working with them, look at the hurdles, look at the IT, and again, that you have to be able to integrate that electronic health record
Right.
into
with billing.
whatever we do this mobile. And
Yeah.
if we do it right and we have good technology in there, then the hospital is asked if they can rent the vehicle, and they can just snap their laptops in and run vaccine clinics or whatever they want to do. So, and if we can lease the vehicle to them, maybe that'll help pay the maintenance expense, so. And then we have, this other thing is the pilot program, and I'll talk about that separately, but those are the three big things. County planning, mobile health, and the pilot program. So, okay. That's kind of my strategic look for the year, barring whatever comes up on the horizon. It can all change depending on what the legislature and the feds do with funding. So
That's
we'll
what
have
I was gonna ask you on the fiscal.
so fiscal. So if you want me to jump right into fiscal, but that's a thing, right? You'll all have the PowerPoint, and I'm just going to really quickly brush through the PowerPoint. So, okay. This cash flow past 5 years. The first 3 years, public health has over the years been very, very consistent in where we're at. High months, low months. We always coast the last 3 months. When FPHS came in, and you sorted out the COVID money from that, and went back to traditional, and that's what this is our traditional public health funding. It's coming at different times of the year and at larger amounts, depending on when DOH gets their contract to us. Because it takes them a while to get the contract out, and then it goes through our legislative process, goes back to DOH, and then the funds come forward. So it looks different than it has in the past. So typically we get a large influx of funds. Now in January, we get a large influx of funds in July, and then at odd times other contracts kick in. So we operate under a document called the Consolidated Contract, the CONCON. And in the CONCON we have multiple pieces. We have fee-for-service pieces. So think environmental health. We have contract work that we do for DOH as their contract entity. So maternal child health, vaccines, all those programs, very traditional public health programs. And we operate under contract where we bill for service. Okay. Then we have FPHS, which is cash that comes to us ahead of time, in different categories. So there's a big block of funds, but there's different categories that have brackets around what you can use each fund for. So there's from the policy committee says, we want you to use X number of dollars for environmental health, water, and we want you to use communications, and so we have those funds. And Casey and Melissa and Ian and I work out how much of each goes to what. That's really expanded our capability to do things. For example, communications, we've never had before, so we have Emily who's doing our communications. Vlad back here is entirely funded by FPHS funding that was specifically designed for FPHS environmental health leadership. So the clinic manager, we're getting some definitions written so we can use life course work. So think birth to death, and use that to fund the clinic manager, because I think that fits kind of neatly in there. A lot of debate around how we use funds in a clinical way, because they're not designed to be clinical services. So we're, as a group, we're having those discussions. So we'll see where that goes. How are we looking? So our cash flow is good. I gave you some history. Fund balance. So the fund balance in this chart, the bar chart, basically shows that at one point the treasurer takes money out. So if we have a fund balance that's their cash balance, they take it out and they invest it. And we come back and tap that fund as we need it down the road. So that's why you see in the yellow the big drop. That comes from when we took investments out. And our investments did pretty good this year. I think we had $190,000 of interest.
For all of us.
Yeah.
We've all been doing good.
Investments have done well. So revenue is budgeted. So the revenue, federal dollars, we're about even with what we expected. State funding was better than what we expected this last year. And then everything else is really basically what we projected is what we got.
So based on everything going back in Washington DC right now, do you anticipate the funding staying status quo?
I think so, because we have our federal funding, as we get back to revenues by source, which is the next one, is 22% of our funding, and it's passed through, and we're under contract already for it. So unless they go back and cancel contracts, we're still under contract. Now, that could change in October. So when the new federal fiscal year starts, that could change.
If you have friends that are doing stuff like this morning, we got an email from emergency management talking about the possibility of money drying up. This is actually the opportunity for it to be the opposite, for it to come directly to local. They're gonna start to try and move funds directly to states. If we have friends, we need to have them remembering it can also come directly to the counties. The same rule applies. The states are better at doing it than the federal government is for dispersing money. The counties are better than the states.
Mm-hmm.
So if you got your friends, please express that so we can get the funds here.
Right. So I think federal dollars we're okay. State dollars we're already under contract until July 1st. So it depends then on what the legislature does during this session. And from what I've heard from the legislature, and I talked to a number of them over the weekend, they're not looking to cut foundational public health because we got that written into law in 2019. So that was the year I was chair of the Rural Health, or the Washington Public Health Association, and we got it through. So we got that written into law, and they're going to honor that. They're looking at maybe doing a $5 million cut. That's $5 million and $240 million. So I don't see it affecting us here. I see it probably being taken up at DOH. DOH has been asked to cut their budget 6% and 25% in their administrative costs. So DOH is going to probably see more of those cuts than we will out here in the counties. And FPHS comes to us directly from the Treasury to the county. It goes through DOH because it has to go through an account somewhere. But DOH does not control the funds that come to us from the legislature. So we were under DOH, local health jurisdictions, tribes, and the state Board of Health. So all four of those have to agree on how the money's spent or nobody gets it. So it's a different system than it was before where DOH got to decide who got what and how much. So allocations now for FPHS funding are different. So you have to have concurrence or nobody gets it. So that really has worked into the advantage of counties. And we do all the reporting. So it's interesting that we do all the reporting on FPHS, We have to tell DOH and the legislature, I have to have a yearly report to the ledge. But DOH does not share how they spend the money. So it's,
Welcome to our whole life,
Yeah.
county government.
right.
What else you got?
Okay, so revenue by source, permits, fees, county contribution is 6%. And when you go to expense by sector, internal charges is 6%. So the money we get from the county, we turn around and hand back to the county to cover the indirects. So intergovernmental is almost non-existent anymore. On expenses, services, our biggest by far is salary, wages, benefits. So we're a service organization, that's what we do.
Yeah.
Okay, expenses are pretty much right on track. What we expected to spend is what we spent. We actually came out a little bit under in all of our expenses. So salary and wages a little bit under, benefits a little bit under, services a little bit under, and supplies were under as well. Total expenses, we came in basically under budget all the way across. So looking pretty good. We were keeping a handle on our expense, so that looks good. VARS report from DOH. So every year we have to report on exactly how much money we spent in every program, and we have more than 30 different programs that we bill to. So I have to bill my time in 15-minute intervals to whatever program I'm touching at the moment.
Right.
We send that into DOH in May. KCI put that together. It's a really big report. And then it takes them 3 years to get the report back out.
I saw that.
To all of
21
us.
is what it says.
2021 is the most current VARS report. So the states, I don't understand that. I don't understand. And they have somebody working full-time doing this, and it just seems like you would take all that information, stick it in an Excel spreadsheet. And it should-
Well, with the computer age, you'd think that they'd at least be just 1 year behind,
Yeah,
not.
yeah, 3 years old.
Which is AI.
Yeah.
So the last thing is county contributions. Basically, we have been level. The 1 year that we didn't get county contributions was 2021, and we replaced those funds with COVID funds. So we had a lot of COVID funds that year and didn't touch our county contributions. So other than that, county contributions has been the same really for a decade. So we're going to probably in this next budget cycle ask for a little bit more because our indirect rates are going up, our indirect costs are going up, and not all of our contracts come with the ability to charge indirects. So that's something we'll have to look at. Okay, next thing, that covers finance. So are there any questions on fiscal things?
Read it through.
Okay. Pilot program. So starting in November, we actually, way before November, last summer, we were looking at dealing with one of my disappointments with our programs that we have, specifically around the syringe exchange program, is we're not doing a good job of getting people into services. You know, we get them syringe exchange, but we don't get treatment. How do we change that dynamic? And we interviewed a number of companies. We talked to, Commissioner Trask was with me when we interviewed a company out of Oregon. But most of the companies had specific niche markets they were looking at. One was all about veterans. One was all about prisons, not even jails, but just prisons. Different groups using different technologies. And we came to United We Care, which is a group out of San Francisco that uses cell phone technology as the starting point to get people into services. So what we're looking at doing, and we've got approval from the county, but I've got some hurdles I still need to fix. It uses cell phones, so a person goes in, we put the app on their phone, and they're able to access through AI. It does some interviewing, and then based on interviewing through AI, it connects them with a live person. And they can use it as many times as they want during the pilot program. So it connects them either with a counselor, a therapist, or a certified listener. Never even heard of a certified listener, but they got them.
And they're certified.
And they're certified. Yeah,
What did it take to become a certified listener?
yeah, I don't know.
I remember we had a school board member that had a doctorate in rhetoric.
Yeah.
So,
He was
yeah, no,
really good at
I'm
taking
not
whatever
kidding, that
he
is an
said and
actual,
making
and
it
really,
fun.
but that's how life is.
Yeah.
That's what the world we have now.
Right.
So the services they get won't be face-to-face, they'll be via cell phone.
Be a cell phone, right. So it's a 90-day pilot. It's $200,000. We're looking at using the treatment sales tax funds balance to do that. And then the data we collect from that, we're ready to take to the legislature and see if we can get this funded on a local or regional basis, ongoing. The cost per person over the 3-month trial is $80 per person for 2,500 people. So I did talk to the hospital and said, okay, well, I don't want to bump into your behavioral health stuff. And the hospital said, absolutely not. We have 8 times as much demand as
I
what we
was
can
gonna
supply.
say, it's out there.
Started with 2 behavioral health people last year, they're at 7.
Yeah,
There's,
there's,
part of our remodel is expanding their,
right, there's
It's-
way more demand.
It's needed
Yeah.
everywhere.
So,
So I'm confused on the cost though, you said $200,000,
mhm.
but then you
Right.
pay per person.
No, that's what the cost, if you break it down from 2,500 people in the pilot program, would be $80 per person.
Oh, I see, okay.
So if we go over 2,500, the company's agreed to pick those up at no extra cost. My concern is I need to make sure that I get at least 2,500 people in the program. And so we want to certainly reach out to the tribes, and this, so anybody can prescribe it. So the hospital can prescribe it, our folks in the Insurance Exchange can do it, tribes. So Ritu, who is the president of the company, is going to come up next week and meet with us. So we'll try to get me, Mark, and Pat, who's on the Behavioral Health and Human Services Board, and then see if anybody else wants to come.
They are getting, in the ER, going after a model similar to what the police department and sheriff's department use with the co-responders, so that they won't, no longer be a nurse or a provider that has to sit with somebody who comes into the ER.
Okay.
It will be I call them a counselor, they're not certified counselor, but something similar. So
Right.
similar to correspondent. So that may play well into what you're talking about.
Right. Because then they can hook them right into the
Yes.
service. We put it right on their phone.
While they're sitting there in the hospital.
Right. So, and they're going to set up an integration team that will work with us. I think they're setting up 4 people that will be out there actually, getting physicians set up with how do you do this, how do you get people involved. So, working on that, working out the last of the bugs on that. So, it's we're looking at using how do you use technology so people get treatment in their own homes and not have to travel to get treatment. And I think that's gonna be the wave of the future, is how we do that. So public health needs to step in and figure that out up front and be, Mason County might be the leader on that in the state. We'll get some great data, and then I'd like to go back to the legislature, and I've already primed the pump there, talked to a few of them about if this, depending on our data, we'd like to move forward, because it's, the governor says that's his, one of his priorities is mental health, so I'd like to see that move forward.
Let's just hope you get the data.
Just, get the data. Gotta get it. So we'll be able to collect how many people use it, how many times they interact with it, demographics. If they interact with it, what was it for? Was it for anxiety, depression, sleep, pain? Be able to sift out what people are trying to interact for.
So does addiction fall into the behavioral health services?
Yeah, addiction, all those things. We'll be able to look at those things. A broad variety of addictions. So. And it's not aimed specifically at the Medicaid population. So we went to Choice, and because it wasn't aimed at the Medicaid population specifically, Choice said no. Because that's going to be their focus, is just the Medicaid population. Okay, there's that. We've looked at other grants, but we came back, treatment sales tax, we have money in that, so we thought, give the commission, ask the commission, they approved that, so. I just want to make sure that integration goes forward. I want to make sure that all the pieces are in place before I sign my name on that dotted line, and finish the commitment. So these are things I want to keep, in front of the board, so you guys.
Yeah, you don't wanna spend that much money and not have it set up before you start.
Right, exactly. So,
What else you got?
what else? He's moving me right along. Tracking that with. Okay, enacting health officer coverage, we have covered. So the only other thing I had was just something to add, and if it pleases the board, we always miss this, it seems. National Public Health Week. And it's in April.
It's kind of no brainer. I've sent it to the commission.
We'll just send it to the commission and get them to sign off on it.
Yeah, we can't have a vote for it, but I think we all have head nods, right?
Yeah, yeah.
And
So-
we'll have them, if it's in April, and we have a meeting in March now.
Yeah, so we'll be able to do that.
Also
Yeah.
send it to the city and get your buttons that worked in the past.
Yeah.
Right.
We wore them, right?
Yeah. So we'll get that sent out, and that's just kind of some happy stuff. We've got lots of good communication stuff going on. Emily has just been crackerjack at getting good communication stuff out there, so.
Good.
And one other piece of news is that Mason Matters has hired a executive director. So remember when Kim Clint was here and put a great job?
Yep.
We've got another one, I think it's just like that, so.
That's wonderful.
We'll be able to take that work, the forums, hand that off to an executive director in the same way that we did with Kim years and years ago. And then not have to depend on choice to do that work, keep that work inside the counties, and keep it directed here locally, so. That's it.
Okay. Ian, Darth Vader.
I was gonna say, it looks pretty evil up there.
He does every time, yeah.
Evil
What happened
Eagles.
to being Frankie or Freddie Mercury?
Okay, I'll go with that one. We'll all sing the chorus with you. I see a little silhouette of a man.
I can't relate. I don't have a singing voice today. I'm out sick. That's why I'm not with you today. So I apologize for not being there. So one of the things I wanted to do today was to introduce Vladimir. I don't know if you guys got to meet him or talk to him at all, but he's sitting over there. I can see his shoes. That's about all I can see. And he's the new environmental health supervisor. So he's my backup, and he's kind of the frontline supervisor, so I can work on policy changes and regulation changes, of which we need many. Also, applying for grant money and things like that. Did anyone have any questions about the Board of Health report that I submitted?
Anybody?
No, just the numbers for the avian flu. It was different and I'm assuming
Yeah.
that this is January 28th and
That was
the report was for the end
year
of last
before,
year.
yeah.
Yeah, it's
I'm
hard to
just
say.
assuming-
I saw those differences in numbers, and I went with the most current one that I could find.
And that's what
I
I
think
was
20 is what I reported in my report.
Yep.
And then I wanted to give you guys a sneak peek of our food database that we have. So don't pay attention to the website because you guys aren't supposed to see this yet. This is supposed to be the county's new website starting in February. But our Inspectago database is available and will be available with the new website in February. And it's really great. It's really great for transparency. So you can search for food service facilities by name, and it brings up the entire food inspection. So I'm just going to go with the easy one with McDonald's. Oops. I should have gone with the pre-fill. There we go. So McDonald's, and then we can see that we've only done 300 inspections that are in this database now, but you can see we have an inspection that occurred back in November. So we can look at the PDF of the inspection. And then this is the actual inspection form. And it has, any points that they got. You can see this facility had, 0 red points. So red points are the bad ones. Those are the ones that make people sick. Blue points are like sanitation violations, so minor cleaning things and stuff like that. The red ones are like, this problem will cause a foodborne illness if it continues, or is likely to cause a foodborne illness. And, that depends on the people that are exposed. But you can see that's the cover sheet of the inspection. You can see there's a comment section. This is everything that staff observed during this. Looks like this was related to a complaint investigation. So then we have, temperatures, the temperatures they observed. It's signed by the facility owner. This one doesn't have it, but if we take pictures during the inspection, the pictures are also in here. So this is, I think, really great for transparency with folks, and also it'll be very helpful for us when it comes to records requests, because we get a lot of records requests for inspections
Direct
for
to the
facilities, and
Yeah.
people no longer have to,
Ain't that
fill out a
simple,
record
can't just
request
do
and
that.
pay 50 cents a copy, etc. They can just go right here and they can search for the inspections, they can see all the inspections, they can go, look at as many facilities as they want.
That's cool.
So we're very excited about this. And like I said, this should be available on the new website in February.
That's cool. Yeah, I'm excited
Actually, they
about
told
it.
us the plans next week, so I don't know if you've heard more than I have.
I think that was the plan. It goes live, I think, the 1st of February.
Yeah. Any questions about the database?
No, that's
Nope, I
cool.
see none.
All right, well, that's all I've got for you. Thank you very much.
All right, I don't
Thank
see
you.
Melissa online. Are you taking Melissa?
No, Melissa is at an appointment. So as far as community health goes, they're in the new building. I think the signs are up now. We had permanent signs built, and the space is up there. We've completed the communication room, so we have cameras and microphones, and we can do podcasts. We can do all kinds of things. So one of the things we're going to be doing up front there is we have a screen next to the front counter. And we're going to put how to get a birth certificate or death certificate in Mon and Conoval on the screen. So people, when they come in, have the opportunity to hear that in their own language. So we'll get somebody to come in, and sit them down, and
That's cool.
do a class. So they have it on the screen. So communications are going well. It's a nice building. People are used to going up there now, so it's working very well for us. And they certainly have lots more room. And the lobby is just beautiful up there. And it's nice not to have everybody crammed in, trying to get environmental health permits and birth certificates and death certificates and all that stuff in the same place in that, tiny little space. Everybody's spread out. It's much nicer. It's made things better at the counter over at Building 8, because you're only dealing with environmental health stuff. So it's been a lot better. It's been a good move for them. And then, not this Friday, but the following Friday, we're gonna have an all-staff meeting, and that's gonna be up at PUD. So we'll be out of office up there for one day to do our all-staff meeting. Other than that, we're trying to hire ARP and get programs up and running.
I got two things for you. I'm disappointed when Commissioner Shute was here, he was very much on board with the idea of getting the Narcan out there and stuff. And I was willing to do it, and we've lost a couple of big opportunities and stuff that ever came of it. There's another one here that I see that I loved when I first saw it. I mean, I loved it, and I'm shocked that we're not doing more, finding more ways of getting out there, and that is those lockable medication bags.
Okay.
They're such a winner for, my community out there, I can tell you, and how many do we have on hand? Are we prepared to be able to do something if we were to create an event to make it happen? in
I think so.
our
I can
community?
find out from Ben, yeah.
Please,
Is that the same ones for the lockable marijuana thing?
yes.
Yeah, that's what
Okay.
Yeah,
But it
lock
can be
them.
used for so many different things in
Right.
their household. It could even, nobody's gonna wanna hear this, but it could even be used for a firearm if it had to. Anything that keeps those children safe and
Yep.
stuff is a smart move. And when I saw those, you don't have to be smart enough to have all the answers, you gotta know them when you see it. I saw it and it's like that, for my community, that is, I'd like to have,
Yeah.
huge amounts that we can do. And I'll even put on some type of function to get them out there to them.
Okay. Okay, anyway, we've got, I think, coming up, a Turn In Your Meds event coming up.
Who?
Turn In Your Meds,
Oh, yep.
so.
Of course, they can do that anytime they want at QFC.
Right. Yeah, there are a number of places around.
Yeah,
We
I
need to get
think
that
safely,
communication
too.
back out again, because
Yeah.
there's places where you can turn in their
But
meds.
for this, I can put some together in the community for the elderly and have them be able to get theirs to protect their grandkids. There's other stuff we could do with, just the regular community. It's always amazes me that, that answers can be that simple.
Right.
And they may not wanna pay for it. Remember, they tried to do it to where it was allowable in marijuana stores, and at first it was completely illegal. They were not allowed to give anything away for free. Even if it was gonna protect the kids. But I don't know what we have for access and,
Anyway, and I think we can find some funding to do that, so.
okay.
That'd be fun.
That's all I have on that. Anybody have anything else on that? All right, then with that, we're gonna go to other business and board discussion. Is there any discussion or anything from the board? Hearing none, then I'm gonna move right on to public comment. Hi, public. What comments you got for us?
So my name's Constance Simpson, and people are wondering, and also particularly the Lower Hood Canal Watershed Coalition, that basically, and I think that Ian has, it's been asked at OSAC meetings and also the Clean Water District, is that the county is not going to spend any money basically out of general funds on environmental health. That's the answer basically that we're getting.
That-
I saw a little thing on the pie chart that just said for county contribution to
Yeah,
public
see,
health in
what-
general was 3%, but, so, because there are some issues, I'm really concerned that we don't seem to be moving much beyond 30% kind of compliance with operation and maintenance, I mean, forever. And I'm wondering, sometimes I wonder, am I part of that 30%? I mean, is it the same 30% that are in compliance? I think we have to move the needle on that, and that's gonna take some money, and it's gonna take some enforcement. So I think that it needs to be discussed. To me, when I look at that and I look at the budget, I say to myself, because a budget is the priorities of the county, is that public health is not a priority. Unless we're getting money from someplace else, then we're not gonna spend it. You know, then it's not important. And I don't think that shows, really kind of, it may show the local, who knows, it may show what local people wanna do. They just don't wanna have anybody telling them what to do with their septic systems, but I think other people do, and water quality is really important. So that's what I'd like you to talk about. Is there any way that you think that you will be able to do that?
Well, if you'd like, I'll talk to you afterwards with what mine is and what I think.
Okay.
Everybody has their own opinions on it. It's not something on the agenda for today, but they
Well-
want to have that discussion. But I myself, when I look at a budget, I look at the whole thing. I have monies coming in from all over in every pot. And that's still the county that's making it all happen. And then we base a lot of the things and decisions we make on the requests we get that may be outside of that or within that. To me, it's all still the county money. So it's not just as simple as saying this is the line. But I'll talk to you more about it, I'll be happy to later, but maybe in the future, the board might want to put something on there to have further discussion on that.
I would appreciate if it's on a board agenda with some backup material also.
Okay, thank you.
Okay.
Deidre, you're public, you got anything you want to say?
No.
All right. Hearing none, I will entertain a motion to adjourn.
I so move.
I'll second.
And no objection? We're adjourned. Thank you, everybody. Next time, it's all you, Tag.
Tag, you're in. Usually you get those.